Hi, I'm Henrietta. Welcome to the show. Every year during the second week in August, communities throughout this country observe National Health Center Week. When we think of community health centers, we might think of free community clinics serving such populations as the homeless, the poor, and the disabled. But is this a view that corresponds with reality? On this show, I have three guests who will share their experiences working with community health centers and their views on what we should know about them. On my left is Louisa Boada, the Chief Executive Officer of the Ravenswood Family Health Center, a community health center located in East Palo Alto. Louisa has worked with community health centers on strategic and financial planning, organizational development, architectural planning, and bilingual board training since 1986. My next guest is Dr. Jeanette Avalos, who is the Medical Director of Primary Care Services at the San Mateo Medical Center. Dr. Avalos oversees all primary health clinics in San Mateo County. My third guest is Dr. Deepa Srinivasan, who is the Medical Director of the Mayview Community Health Center in Palo Alto. Welcome to the show. Thank you so much for joining me. Now, I mentioned at the top of the show that when we think of health centers, we usually think of clinics that serve the poor, the disabled, the homeless. Is that correct?
Well, there's many aspects of that that's true. We consider ourselves a safety net provider for those people who have limited access to healthcare or barriers to healthcare, and they could be financial, they could be lifestyle, they could be isolation, such as in rural areas. It's not just urban. So yes, it is true that we serve those populations. What you mentioned earlier about being free, that's not the case, and we can talk about that more.
Oh, okay, that's good. That's very important. Anything you'd like to add?
No, I would agree. I think that we are here to serve the most disenfranchised, and I think Louisa is right, they aren't free, but I do think that at the heart of what we do is this idea that our community is beyond just the geographic area. It's really developed groups of people who really normally can't get access that easily. And it represents a lot more than just an area, a geographic area. It's much more complicated.
That's interesting, something we can get back to. Anything that you would like to add?
I agree with Louisa that it does represent the geographic area, because Mayview seems to also serve the Stanford community, and there are a lot of Stanford alumni and graduates who you wouldn't think would go to a community center who do come, and they're CEOs of companies and don't have insurance. And I was amazed at sort of the broad spectrum. It's not your typical, what you would think of as a community health center patient coming in at Mayview.
Oh, that's quite interesting. And that could be because it's located in Palo Alto.
Well,
right?
we have an office in Palo Alto. The demographic in Sunnyvale is slightly different, and we have another office in Mountain View. So it depends on the location, but the Palo Alto location is on California Avenue. It's part of the courthouse. So.
Sure. Now, I remember you said they're not free. I can remember, maybe when legislation was signed granting Medicare, Medicaid, that clinics were free at that particular time, unless I'm mistaken. Now, were they ever free, to your knowledge?
So the legislation that was passed that allowed community health centers to be funded, which is Public Law 330, it's a federal law, was back in 1964. And it was at the same time of civil rights. And so the first clinics were free because they were in urban Boston, and in Bayou, Mississippi was a rural one. And the U.S. government at that time paid for 100% for the health centers. These were people, at that time Medicaid hadn't been fully established or in place, and so there was no way to pay for care. And so they were free and they were funded. Over time, the federal government has looked to health centers to look to local funding and then other philanthropic sources and all kinds of public sources like Medicaid, Medicare. In California, we have a lot of categorical programs that pay for the services as well. But federal funding, when you are federally funded, usually only represents about 20% of your total budget. And that's because I'm a grantee, a federal grantee, which is called a federally qualified health center. Whereas I know Mayview is what we call a look-alike, so they don't get that federal grant, but they get a lot of other benefits that are similar.
Now, you had mentioned, Dr. Avalos, that it's the concentration or the focus isn't geographic. Now, I'm thinking for San Mateo County, since you're overseeing all of the health centers in the county, that might not be geographic. Or what did you mean?
Right, so I think I meant two things. One, San Mateo County is very broad in its geographic distribution. We have a lot of clinics ranging all the way from the northern part in Daly City and South San Francisco, all the way as far south as Fair Oaks. We have at least 9 different primary care sites, depending on how you count them. And I think that each one of them serves a general geographic community, but as a system, we are also serving, I think, a group of people who don't always have access, understanding, information about how to get their care. So I think of the community as both a geographic one, but probably also a social economic one.
Now, it was amazing what you said, Deepa, in terms of it not being geographic and the fact that professors come in and students from Stanford come in. Why would they come to a health center, which one thinks of as a clinic?
Right, we actually have a lot of volunteers from Stanford students who work at our clinic, and so I think there's more exposure and people know about Mayview in the Stanford community. And also the location on California Avenue and just being close to all the startups, there are a lot of entrepreneurs who don't have insurance, and it seems to be a word of mouth type of thing. So, you know, when I started, I did not expect to see CEOs of startups coming in along with people who really are disenfranchised. So we're advocating for basically the health of the community as a whole, the entire spectrum. So I think it really varies on the location of where you're located, I mean, the community that's around that clinic. Because of our proximity to Stanford, Stanford does have some impact, especially at the Palo Alto location.
But if they're students of Stanford, wouldn't they have Stanford has its own medical services?
Right, which is limited. It's just the student health services, and sometimes, for example, they'll come in for HIV testing or contraceptives, which I don't know if it's readily available in our center, and they feel more comfortable coming in, especially since it's a smaller, more intimate setup versus the student health center.
Sure. Now, I think you said, Louisa, that the Ravenswood Family Health Center, 20% of its funding comes from the federal government, and the services are not free. So since we're dealing with indigent people, in many cases, or the homeless or the poor, how do they pay?
So there's a sliding fee scale. We're required for people under 200% of poverty, and that's based on the number of people in the family and the family income. We are required to provide a sliding fee scale based on their income. Under 100% of poverty, we have to provide them no more than a nominal fee, which in our case is $20 for a full visit that includes everything, their lab, their medications, all of these kinds of things. And so you have to see people regardless of ability to pay. So we see them whether they show up with their $20 or not. We do bill them, we ask them to pay because we need to have that, you know, we need their portion. And I think also people, the truth of the matter is I think people respect care when they have an opportunity to pay something. I think people feel better about themselves, and they also feel like, you know, they're buying something of value when they have something to contribute. The majority of the people, I think, have pride in their ability to pay the little bit that they can pay, but they're not able to pay certainly full freight.
Is that, yes, I was going to say,
At San Mateo, so we are also a federally qualified health center with multiple sites, and I think from that same lens, you know, the patients that are under the 200%, as Louisa mentioned, they do have less cost up front. They do have some copays, they're fairly nominal, but we also have patients who have or qualify for Medicare and Medi-Cal, and from their perspective, there may be no copays. So this idea of free, I think, is when you're saying free, it's, you know, does the patient or the client that's coming into a system, do they have to pay for it, right? Ultimately, there's costs that we incur for all of the services that we provide, but we try to make that as livable, especially in our community. For
Well, given
patients.
the cost of health care, it makes me think, since health care is sometimes tied up with cost, how adequately are these patients being served?
Well,
Well,
I mean, well, you're both physicians. I'm a nurse, but I think we provide the same, well, even better level of care, because we also address the socioeconomic issues, the need
Right.
for resources that people have, transportation. We help them get, food and clothing, and we have a farmers market, and we teach classes, and we provide incentives, for example, for pregnant women.
How can you afford all of that? I mean, those are a lot of
This is part of-
services. Those are comprehensive services. When I think of a health clinic or a health center, really, I think of a health clinic, a clinic. So how can you afford to supply all of those services?
These are the things that are part of your health when you come to a clinic. And I think, in terms of affording it, again, there are challenges. The resources are not broad, but it is part of our mission to really provide these clients, these patients with a really integrated system. We're fortunate at San Mateo because we're a larger health system. So we have the clinical side, but we also have the behavioral health and the mental health resources, some of which is federally funded, some of which is grants. There's all sorts of different funding sources that come into there. But these are essential pieces, I think, of providing quality care to patients. You can't do it without that.
Is that your experience working at Mayview?
Well, Santa Clara County does contribute to our clinic, and the majority is fee for service. Like as we were mentioning, patients are paying what they can pay, and a lot of these patients will pay the full price. And
Which might be
it could be up to $150 to $200 if they're capable of paying it. They
per
pay
visit.
per visit, depending on the level of care we're giving and the problems we're addressing. And we do get a lot of donor contributions from Silicon Valley, and we try to do fundraising and just raise awareness in the community. A lot of people don't even know we exist, especially Mayview. We're kind of a smaller community clinic compared to Ravenswood, who's gotten funding from Facebook as well, right, recently?
Well, from Mark Zuckerberg and Priscilla Chan, from their family foundation.
From their families.
There was a capital grant for our new building.
Got it.
Yes.
So we faced our own challenges in terms of just spreading awareness that we exist, because our clinic in Palo Alto is hidden in the courthout. So when sometimes patients don't even see it themselves. So.
And would they be comfortable going to a courthouse? I mean,
It is what it is. They gave us the facilities rent-free, so we're grateful to the county for that.
so in terms of quality of care, it seems that, because I was wondering, what do the clinics or the health centers offer that regular medical facilities don't offer, if there is anything? And you mentioned integrative health care. And so what does that involve? Do you sit down with each patient and do an entry analysis, unless it's an emergency? So how do you get to provide full service?
I think in our clinics, the heart of where we begin is people really passionately committed to the health of community. So that's the heart. If you're not committed to that level, you're probably not going to be there, because financially, it's not a win for most people that work there. They work there because they believe in the health of community. And so you start with that, and then you build what you can with the resources you have, and you measure to see if you're using them the best way that you can. And providing quality nowadays is really measuring, not just what are we doing one by one, but what are the outcomes of this group? How healthy are they? Are we making a difference?
As a group or as
Both.
Individuals?
Both.
So when you look at a group, what are you looking at? I mean, how do you measure
Well,
providing health
We're
services
required
to
all
a
have
group?
electronic health record now. So I believe we all have
We do.
electronic health record. And so we also have a population registry, and we harvest data, and we look at the data both on an individual level, and when we say a population, we'll look at all our hypertensives or all of our women who need mammograms, or all our diabetics, and we look at the fact,
all are homeless.
or all are homeless, and look at, you know, all of their indicators of health or illness, and we measure whether we're meeting the national benchmark or, you know, the healthy 2020
There's lots of
goals.
metrics out
There's
there.
lots of metrics out there that we have over 400 metrics that we're measuring that are about the quality of, well, the outcome of the patient's care, and are they getting better, and are they're activated in their own health, you know, are we improving their hemoglobin A1C if they're diabetics, et cetera. You know, did we get their foot exams? Did they get their mammograms and their PAPs? Did we follow up on their mammograms and their PAPs?
And the truth of right now is that with the ACA, people have Medi-Cal, people have options. They don't have to. I mean, all
I assume that's the Affordable Care Act.
It is,
ACA.
yes,
Okay.
the Affordable Care Act. With Covered California, with enrollment, coverage has expanded, and so whereas before your choices might have been more limited, now there are more. And how well we provide the care comes down to some of these measurements, whether we're culturally and linguistically appropriate for them. So all of this is a piece of providing quality in today.
Do you have the same type of requirements? Do you have the metrics that you have to consider?
Yes, we do. We have a quality person who actually goes through each physician's panel and keeps track of what we're doing. And we have people calling in patients, reminding them to come in for their annual checkup, or you know, they forgot to do a mammogram. They have lists of people due for hemoglobin A1Cs for diabetes. So there's a whole team, everyone from the medical assistant to there's a patient services coordinator as well. And it's more of a family network where everyone seems to feel like they're taking care of the community, and they're, in our clinic in Mayview, most of them speak Spanish. I speak Spanish as well. I grew up in Mexico City, although I'm Indian originally, but I do feel a certain affinity with that group, and so as a result we're culturally competent. And I think a lot of our Hispanic population, they're nervous to go to another clinic where they don't understand their culture, and they are more comfortable coming to us because we're like a neighborhood clinic for them.
How did all of this get started? I mean, one doesn't think necessarily, when you think of health centers, of this type of intimate individual care and attention. So how did all of this get started?
So interestingly, there were two doctors who went into the Peace Corps, and when they came out of the Peace Corps, they were in Africa. They came back, and they'd worked in clinics in Africa, and they couldn't understand why in the United States we had a really high infant mortality rate, particularly in the African American population at that time. You know, that was just when civil rights was starting, and so there were, basically, if you didn't have, there was no law that said if you went to the ER, you had to get care. Today there is. They have to attend you. In those days, they could turn you away and let you die if you didn't have a way to pay.
We're talking about maybe 1964 in that
1960s.
time?
Well, that law that you can't turn people away was passed in 1981. So even though that we're talking about 1964 when the first clinics were established, what they did is when they came back, they said, we can do this here. And their focus, particularly in the rural area in Bayou, Mississippi, was, you know, getting people basic public health, latrines in their houses, clean water. And interestingly enough, Dr. Geiger was giving people prescriptions to buy food. And the people from the Department of Health Services from the federal government came down and said, how dare you give people prescriptions to buy food? And he said, well, my understanding was to treat malnutrition, you had to give people food to eat. And so that's why we're using the federal money to give people food. And so their whole focus when the clinic started, I mean, federally qualified health centers and clinics in this country have a big focus on public health, because we know that the social determinant, one of the biggest social determinants of health, whether you have health or not, is poverty and good nutrition and living in a healthy community where people aren't being shot at and killed and on drugs, and you know, having good mental health. So we know those social determinants of health, and that's what we try to treat. Giving people pills is not how we make people healthy. It's helping them have a healthier lifestyle, living in healthy communities. So we work outside of our four walls.
Absolutely. It's having housing, it's having
Yes.
food. And you can't think about your health until the really basic things are addressed. And even once we are giving the medicines are a piece of your care, but how we use team, this idea that it isn't just a one-on-one with a physician anymore, it really is a bigger team. It's an effort, and the patient doesn't just need answers from their primary care provider. They really need answers from a group of people that take care of their
Well,
whole health.
as I listen to you, I have medical insurance, and I'm thinking with a hospital, maybe I should just go to a health center where I could
And this
have
is the
integrative
transformation.
care.
And we actually have some patients who choose to do so. And we have board members who are patients who are so grateful for the services that we're giving them that they want to advocate for the clinic as well. So we have patients who could afford to go anywhere but choose to come to us and support us and give us their insurance money or their money to support our clinic so that we're viable.
Now, I had mentioned in introducing the topic that there are communities throughout the United States celebrating National Health Center Week. Are there clinics or centers like the one we're talking about located throughout the United States in all cities?
All 50 states in the country have health centers. There's over 1,200 health center corporations and more than 9,000 health center sites in the United States serving, well, prior to the Affordable Care Act, we were serving over 25 million Americans who either were uninsured or underinsured. And now, since the enrollment, I'm not sure what our total numbers are, but it's bigger. I think of the 7 or 8 million people that enrolled, I think we picked up at least 30% of them.
Because I was thinking, if you have these services and you have them available, and they're throughout the United States, and they're for homeless and the poor and people who are on the edges, then what did we need with the Affordable Care Act?
So I think
Given that this is a health care service that's available to everybody.
So you have to remember that, again, going back to what Lisa said, not all of it was free. I think what the Affordable Care Act has done is has opened the door for people who previously couldn't even afford perhaps the copays or the pieces of
Or the
care.
$20.
Or the $20. And not that they couldn't, but now, if you can put yourselves into the shoes of folks, now I have insurance, now I qualify for Medicaid or Medi-Cal in our state, and that really opens the doors to a group of people who previously probably did not seek care for
And
themselves.
I'm thinking one other thing as I asked that question. I'm thinking Deepa said that one of the biggest challenges for Mayview is to let people know that you're there. So I'm thinking even with the health centers, there is a lot to be done in terms of outreach, isn't there, to let the communities know that these are services that they can get.
And that their health is important on all sorts of levels.
And
I
there's
think.
somebody there that cares about their health.
Yeah. And I think some people believe that, particularly if they hear the word clinic, they think it's not mainstream healthcare. But all of our doctors are board certified. All of our staff have to meet the same credentialing requirements as any other healthcare institution, and all our facilities have to be licensed and certified by the state of California, which are very rigorous standards. So we're held to the same criteria as any mainstream provider, and yet we struggle with fewer resources to be able to do that, and yet we also do more at the same time. So.
I completely
Yeah.
agree. I think there's also, to this idea of if you have insurance, if you do have coverage, our places also can help that person have a home, right? To have a real integrated center for their care. It isn't just the disenfranchised. That's our mission. That's at the heart of what we want to make sure doesn't fall through the cracks and get lost. But we do this for more than just them. That's just the mission that we don't want to lose track of in the middle of everything else.
Now, when you say we do this for more than, what?
It means,
what's the more
the
than?
insured, the people who don't have to come to us but choose to come to us because we are integrated, because we are culturally sensitive, because they can find someone who understands not just their language, although that's a big piece of what we do, but also understands their culture, cares about their home situation, really thinks about their
It sounds
homelessness.
very ideal. I mean, if if you need more funding and perhaps you have not as much staff, how can the centers provide the type of care that you're talking about? It seems comprehensive.
Right.
And I assume, should one assume that it's given to all of the patients or offered to each and every patient that walks through the door?
It is, yes. I really think the people who work at Mayview it's almost like a calling for them. It's beyond just, I mean, going into medicine in general is a calling, but then to do this, you're working harder, you're making less money than you would if you were working for Pamper, Kaiser, or Stanford. So there's something beyond that that's making you work there, that's making you want to serve the community and provide quality health care for the people there. And I have worked in those other facilities, and I still am inspired by the dedication of the staff, you know, who are making minimal paychecks and who are still giving their, you know, their sweat, blood, and tears to make sure these patients get taken care of. So for me, it's been a very inspiring experience, just to see humanity rally up for these patients.
And it is ideal, it sounds ideal, but it isn't in the day-to-day. There's not, it's not like the resources are abundant. It isn't. We're doing this in spite of, not enough.
Right.
Constantly trying to figure out, how do we keep what we do intact? How do we continue to do this? And every day is, you know, a challenge of, you know, how many did we serve? Did we reach enough? You know, what was the real payer mix that was coming in? It's a constant challenge. I don't mean to paint it as it's easy. It's not easy work.
It doesn't
then-
sound easy at all.
Well, and the other
It
thing
sounds
you
almost
said,
impossible.
why the Affordable Care Act? So when you look at the populations that the Affordable Care Act was aimed at, many of the adults who weren't linked to age, blind, disabled, or to families with children had no coverage. Many adults. So if you were a single person or your children had grown up and they were over 18, you couldn't get Medi-Cal if you weren't 65 and low income. And so a lot of people were left out of the system and
And
uninsured.
they waited to get sicker.
And they waited to get sicker to go to the ER, you know, and maybe qualify or spend down all their resources, so they were then eligible, and then they were destitute. And then you got to remember that if they had private insurance, you could be kicked off after you hit a certain limit, or you could be kicked off for pre-existing condition. Employers didn't cover people. My son, for example, when he turned 18, would have been thrown off because he didn't go to school full time. And fortunately, he turned 18 the year that the Affordable Care Act started, and he was able to get on my insurance plan and continue until he had a full-time job and had his own insurance. I couldn't have covered him, and he had asthma, so he needed his medicines. So it's, you know, these are the kinds of things that, you know, people have had to deal with, and it costs a lot for families to have to pay for all that, or especially worse if they had a catastrophic situation.
So, given the picture that the three of you are presenting in terms of the mission of healthcare centers and how you're carrying out that mission and how the Affordable Care Act has allowed more people to come to you, why is there, in your opinion, has there been such opposition to the Affordable Care Act? Which is now, I mean, people have filed for it to go through the Supreme Court again.
I think it's largely a misunderstanding. I think a lot of people have been fed by a lot of political media, a lot of things that aren't true, and you know, and they create fear. And when people are afraid, they say no. And if you don't know how to say yes to something, you say no. It's kind of like, I don't know, people get stuck at a certain age level of development where if you don't know how to say yes to something because you don't understand it, it's safer, you know, it's like, I know the devil, I know, I don't know the devil, I don't know.
Well, sometimes if you can't say yes, maybe you just don't say anything and you wait and see
And people are
until you
afraid.
have enough information to make an informed opinion, huh?
Yeah.
People
Or
are
is it
afraid.
easier just to go with the voices that are closest to you?
I think there is definitely an element of that. I think that people are also afraid of the change, of perceptions perhaps of how it's going to impact them, or ideas of if I'm giving more resources so that all have, it must mean that resources are coming from somewhere, and that must mean that it's going to disappear from me.
So,
Or there's a concern that they think the quality of healthcare will somehow be affected as well, or they won't have the choice,
Their choice.
to go wherever they want to still. Those are the sorts of fears I'm hearing from patients.
The other thing too, I mean, it's people, in America, everybody wants to sort of do their own thing, and everybody's a cowboy riding on his lone horse out to the west, and so when the government steps in and says to insurers, you have to use this kind of health plan, and this is what qualifies, and these other things don't qualify, and you have to do it this way. It pushes a button for people who say, gosh darn it, I want, freedom to do anything to anybody
too much
for
government
myself.
interference.
Yeah, and so they're reacting to that and not looking at how it's benefiting people who've been left out.
And potentially themselves. I think this
Yeah,
idea of the
potentially
metrics,
themselves,
this idea, this data that we talked about, it really is reshaping also how we think about medicine in general. Forget, just what we do, everything, right? For this cowboy idea of we're going to do this because it's what I've always done versus does it really work? Is it the right thing? Does it measure out? Is it improving the outcome of a group or of an individual or of both, ideally? And that's changing how we measure